Hello, thank you for joining the ERJ Podcast. My name is Dr. Don Sin. I'm the Deputy Chief Editor of the European Respiratory Journal. Today I'm joined by Professor David Halpin to discuss his editorial entitled Addressing the Global Challenges of COPD and Asthma, a Shared Vision from the Global Initiative for Chronic Obstructive Pulmonary Disease, GOLD, and the Global Initiative for Asthma, GINA. Dr. Halpin is a consultant physician and an honorary professor of respiratory medicine at the University of Exeter. He is also a professor of respiratory medicine at the Observational and Pragmatic Research Institute in Singapore. David, many thanks for joining us today.
Nice to see you again, Don.
In your editorial, you lay out the big global challenges facing the COPD and asthma community today. Would you care to just summarize some of these challenges and the priorities of both GOLD and GINA?
Sure. So, this manuscript emerged out of a discussion that we had between GOLD and GINA, initiated actually by the much missed and late Eric Bateman, where we recognized that there are many similarities between the challenges faced by people with asthma and COPD. There are obviously also differences, but many similarities. If you take a global perspective, one of the key priorities is the growing burden of these diseases, both in high-income countries, but particularly in low and middle-income countries. And that's obviously much more of an issue for COPD as populations age and life expectancy increases. COPD is developing, but also for asthma. In many LMICs, their priority has been on infectious diseases and mortality and morbidity in children from infectious diseases. As those diseases have become treatable or disappeared, then the non-communicable diseases emerge, and asthma is clearly a major problem for children globally. So I think the sheer numerical burden and the future burden is a huge challenge that we both face. There are difficulties around making a diagnosis. Making a diagnosis of hypertension or making a diagnosis of diabetes is actually very simple, but making a diagnosis of asthma and COPD is more complicated. So it requires some degree of equipment, some lung function measurements, but also greater clinical knowledge. So I think there's a global challenge in how you train the workforce, particularly the workforce in primary care, community care, to recognize and diagnose these conditions. Once you made the diagnosis, I think there's a need to access the treatments. I know that the treatments are very effective for COPD and asthma, but a lot of work has shown that in many countries, even in the US, there are challenges about obtaining medication because the insurer will change the supplier, change the contract, and you'll switch from one device to another just because the contract has changed. So I think access to effective medication that is also affordable is a real challenge for many people. And access to specialists, because again, if the diagnosis is a bit uncertain, you need to be able to see a specialist who can confirm the diagnosis. And in many countries, both high and low income, that's a challenge these days. I think on top of that, we have the challenges posed by climate change. That affects everyone, but there are particular challenges for people with respiratory diseases in terms of the effects of temperature, effects of respiratory infections, dust, as you know only too well in Canada, the wildfire smoke. So all of these things together, I think, are global challenges that people with asthma and COPD face that we thought it was worth just highlighting, and also bringing out the fact that although GOLD and GINA are distinct organizations, we are working closely on addressing some of these challenges.
Very good. You've outlined, 3 or 4 major areas of priority for both GOLD and GINA. Let's try to unpack each one of them. Let's first talk about diagnostics and the role of spirometry or something similar to spirometry. Access to spirometry or lack of access to spirometry has been discussed for 30, 40 years. Why haven't we made sufficient progress in this area? What are the major barriers?
Well, I think there are a number of things. One is the perception that it's difficult to do. And I think, perhaps with the old equipment, the requirements for calibration and so on, it was more difficult. But with modern spirometers, particularly with AI assistance, both the coaching of the patients to do the maneuvers correctly and the interpretation is now relatively straightforward. I think doing spirometry is actually simpler than measuring a blood pressure. And in the UK, there was an incentive for primary care that was introduced in the early 90s, where they lost money if they didn't do certain things and their income was restored if they did. And one of those was using spirometry to confirm a diagnosis of COPD. And there's very good data showing that following the introduction of that measure, the use of spirometry to confirm the diagnosis went from about 30% to over 95%. So it is possible to get it done. Once people start doing it, they agree that it's a relatively simple measurement. The interpretation was more challenging in the past, but as I said, I think AI can help with that. It's a bit of an own goal from the respiratory community that's presented this as a difficult test. The physiologists make it sound as though it's almost impossible to do except in a laboratory setting. We need to get the message out there. And as you know, Gold has been promoting the idea that if you get a normal result on spirometry, so a normal ratio, normal FEV1 or FEV1 FVC within the normal ranges, you can't get that by a poor maneuver. It's not an artifactually normal result. So you can exclude COPD as a cause for breathlessness in older people relatively easily in almost all settings. So I think it's false perception about the difficulty of spirometry and the difficulty of interpretation that's really held it back. And as the UK data shows, if you incentivize people, if you reward them, and I know this is a big issue in the US, that the reimbursement for spirometry is a challenge, which is why people are not doing it.
So we have the technology to deploy it widely. It's a matter of education, implementation, and perhaps reimbursement. Is that the feeling?
I think so. And I think it's also a matter of, a lot of people say, oh, it's too difficult. We must think of alternative ways of confirming the diagnosis. I think that's wrong. You wouldn't say that for using an ECG to confirm an MI. You would say everyone needs to have access to an ECG machine. I think the same is true of spirometry. We shouldn't, it may be that in the future there are better techniques or that there are alternatives to spirometry that are more widely applicable particularly in LMICs using mobile phone technology or whatever. But for the moment, I think we have a technique that's actually quite simple and straightforward, and we should be using it, as you say, incentivizing people to do it properly.
Let's move on to therapeutics and climate change, which may in certain cases be related. For most COPD and asthmatic patients, they are used to using inhalers. And you make the point in the editorial that access may be problematic in certain parts of the world, even in the Western Hemisphere, that may be a problem. Could you elaborate on why relatively inexpensive inhalers would be a problem in terms of access?
It is a challenge. Nobody really knows why, but I think although, as you say, inhalers are relatively cheap, compared to most oral medications, they are actually quite expensive. The manufacturing of the device, whether it's a DPI or whether it's a PMDI, is a lot more complicated than formulating a tablet. There are generic versions that are present in many countries, but if you look at the data, something like 80% of all the inhalers used globally are PMDIs. So there's quite a sophisticated manufacture. I think, as respiratory physicians, we take them for granted, but the engineering behind formulating the canister with the propellant, with the right dose of drug in, then the metering dose, and the actual plastic case that a lot of people think is just holding it, but the nozzle in that is also tightly engineered. So I think they are difficult to make, they're more expensive, and their availability to some extent, or the lack of availability, goes along with the lack of awareness of the importance of respiratory diseases. In many of the LMICs, respiratory diseases are not widely known about. As you know, to try and address this, I've been leading work for the Forum of International Respiratory Societies to raise awareness of this problem at the World Health Assembly and then in the autumn at the United Nations high-level meeting on NCDs. And at the meetings that I was talking at to policymakers and to politicians, I would ask them, how many of you know that COPD is the third commonest cause of death worldwide? And less than 10% of these people are aware of that. So following on from that, making inhalers available for their populations is not going to be seen as a priority. And I think the respiratory patients themselves are not a particularly vocal, not a particularly campaigning group of patients. Partly, I think the COPD patients, it's very difficult to campaign if you have COPD, to go to meetings, to advocate for better care for your disease, compared to, say, an MI where you're a high-flying business executive, has an MI in their 50s, recovers, and you want to encourage better care for people with ischemic heart disease. So I think the lack of availability is partly practical in terms of the manufacturing difficulties, but partly also sort of philosophical or political in that they're just not seen as a problem.
You mentioned that 80% of patients use MDIs, meter dose inhalers, globally. And one of the concerns is that the carrier chemical in the MDIs are greenhouse gas, whether it's hydrofluoroalkanes or I guess in some circles, CFCs are still used. I think you recommend switching patients to dry powder inhalers. What would be the implication of doing that kind of switch of 80% of patients who are reliant on MDIs?
We don't actually recommend switching people just willy-nilly to DPIs. I think when there's a choice and when you're initiating therapy, certainly in the UK, NICE would encourage people to consider carbon footprint as one of the factors. But there are some people that can't use DPIs, so it would be inappropriate to give them a DPI. Similarly, just to switch without explanation is not a good idea. So there's a nice study, in JAMA that showed that healthcare utilization went up significantly after a non-consensual, non-clinical switch from PMDIs to DPIs. But in the right setting, a DPI may be a better option. It still has a carbon footprint in terms of its manufacturing. The other option is there are newer propellants that have a much lower global warming potential than the current ones. So for people that need to use a PMDI, and that includes a lot of children who can't really use a DPI, then these newer inhalers may well be the way that we can provide treatment to them in a form that has a lower impact on global warming. But they may be more expensive and it may not be an option for lots of people, again, in LMICs. So I think it's something we need to bear in mind. But it also needs to be balanced against the fact that one of the biggest drivers of carbon footprint in respiratory care is poorly controlled disease. People being admitted to hospital, having exacerbations, has a very high carbon footprint. So even if the inhaler device itself is contributing to global warming, if it's the only way of keeping that patient stable and out of hospital, the overall equation may be favourable. If you put it in perspective, the global emissions from PMDIs are responsible 0.03% of all greenhouse gas emissions. So it's something we need to be aware of, but we also need to care for our patients appropriately.
The other day, I had a patient come in with their albuterol or salbutamol inhaler, which I think is the most commonly used inhaler across the world for both COPD and asthmatic patients. And one of the things that struck me was that there was no counter on that device. And the patient didn't know whether it was empty and couldn't remember how many doses were actuated over the previous couple of months. And I think one of the main contributors to carbon footprint concerns is the disposal of relatively unused salbutamol or other PMDIs, probably because they don't have a counter. Is there a movement afoot to mandate that across the world, to put a simple, counter on PMDI devices?
So I think that's a very important point. I'm not aware of any initiative to put a counter on, and that, of course, increases the cost. The albuterol, salbutamol PMDIs are amongst the cheapest inhalers and are significantly cheaper, maybe 10 times cheaper than the equivalent DPI for salbutamol, albuterol. But I think there's probably a more important message, because even if you use the device to the total number of doses it contains, there's still a significant amount of propellant left in the canister at the end of that time. And if that's simply put in the trash, in the refuse, goes to landfill, is split, releases the propellant, that is a major contribution to the impact of PMDIs on release of greenhouse gases. So appropriate disposal of the even truly empty PMDIs is very important. And most pharmacies, certainly in the UK, will offer a facility where they can be taken, they're incinerated, and in the incineration you destroy the propellant so there is no global warming potential. I know there have been some initiatives in the US and some in Europe as well, but that's, I think, where we should be focusing our attention for everyone on appropriate disposal of their empty or used PMDIs.
And perhaps one last thing, you mentioned access to pulmonary rehabilitation in the document, and that's rarely discussed. Is it because access is so poor that it's not worth discussing, or access is pretty good and we just need to, get patients enrolled?
I mean, as you know, access is terrible. And I think this is one area where there are alternatives. So in situations, particularly again in LMICs, where you don't have formal rehab programs, I think there's good evidence that structured exercise, whether it's in the form of sort of yoga type exercises or Tai Chi or things like that, can be beneficial for people with COPD. But the best is a formal rehab program, and the availability globally is very poor. The reimbursement is generally very limited, and that leads to a catch-22 because clinicians don't refer the patients because they know it's not available. The payers say we're not going to pay for it because nobody needs it, and you get into this sort of spiral of confirming that it's not available. So I think it is something that certainly needs addressing. It's more complicated than making medication available because you have to have programs, you have to have people, you've got the issues of travel. But I think tele-rehab is one way that you can actually improve access now and optimize the use of the people that are involved. But yeah, I think the non-pharmacological aspects of management, just like smoking cessation as well, is something that we need to keep ensuring is available.
Very good. Any last words to the community regarding the document or about COPD and asthma in general?
I mean, I think one of the themes, and I said this right at the very start, is that there is a huge burden of chronic respiratory disease, which is largely unrecognized by people outside the respiratory community. And I think we as clinicians all have a responsibility to make politicians, payers, whoever, the public, aware of that burden and try to advocate for better care for our patients. Because I think, compared to other long-term conditions, respiratory patients get a raw deal.
And the good news is that both COPD and asthma are treatable conditions with the right diagnostics at the right time and therapeutics that are relatively inexpensive, though there will be some cost to it, and that can be widely available throughout all the patients across the world. So on that very positive note, we'll end our podcast, and I want to thank Dr. Halpin for joining us. Professor Halpin's full editorial is now available on the ERJ website. Thank you.